Dear chairmen, dear colleagues, European Association of Urology Congress is started, and during the next several days we will talk a lot about metastatic prostate cancer. And this presentation will be related to metastatic prostate cancer and update regarding this topic, which we can see during the last several years. This is my conflict of interest disclosure slide. And the first point is new data regarding prostate cancer statistics, which showed us that prostate cancer is still most common cancer expected to be diagnosed in men in this year. However, only 11% of all cancers deaths are due to prostate cancer, and all these patients will have metastasis. Let's talk about metastatic hormone-sensitive prostate cancer. And I would like to start with metastatic prostate cancer diagnosis, which changed significantly for the last year. And one of the most significant update is PET-CT and its role in primary staging of metastatic prostate cancer. According to recent several randomized prospective trials, metastatic prostate cancer is more better diagnosed with PET-CT, because accuracy of PET-CT, PSMA PET-CT namely, was 27% higher than that with conventional staging, CT and bone scan. PET-CT can prompt management change more frequently as compared to conventional imaging, up to 28%. PET-CT has lower radiation exposure, but the limitation of PET-CT is higher financial burden, and we don't have long-term clinical outcomes, and we don't know the influence of PET-CT on oncological results. Germline mutations is another metastatic prostate diagnosis tool which can drive the development of aggressive prostate cancer, and according to recent Philadelphia consensus, all patients with metastatic prostate cancer should be considered for germline testing, because up to 12% of men with metastatic prostate cancer harbor germline mutations in 60 genes, including BRCA1-2, ATM, CHEK2, mismatch repair genes, and others. But again, we don't have clear data regarding the treatment strategy changing. CTC is another diagnostic tool which can be promising in metastatic prostate cancer diagnosis, because almost twofold difference in survival rate between undetectable CTC and 5 or more cells in 7.5 milliliters of blood. The number of circulating tumor cells in patients with metastatic hormone-sensitive prostate cancer correlates with survival, and undetectable CTC and even 1 or more circulating tumor cells in blood these patients has different prognosis. Go ahead to metastatic prostate cancer treatment, and being a surgeon and clinical oncologist, I would like to start with surgery in metastatic prostate cancer. Cytoreductive surgery, according to recent data, is feasible or relatively safe. It can be performed in a minimally invasive way, and robotic assisted surgery, the rate of robotic assisted surgery in these patients rise in recent times, but there are currently 9 trials investigating the effectiveness of cytoreductive radical prostatectomy in hormone-sensitive prostate cancer, but we don't have long-term oncological outcomes, and we don't know about benefit of cytoreductive surgery in metastatic prostate cancer, because from these 9 trials, 5 trials are still open and 4 closed recently, but we have only primary results, and the most of cytoreductive radical prostatectomy trials don't define the volume of metastasis. One of this trial, one of the most early and prominent trial, WOMP trial, has early data which were published in the last year, and the conclusion of this trial is improvement of local control in patients with cytoreductive radical prostatectomy. Patients with radical prostatectomy were younger, had lower initial PSA level, and less high-volume metastatic disease. But again, we don't have clear data regarding the oncological results. Radiation therapy is not the same, and recent randomized prospective trials showed us that radiation therapy has promising data in patients with metastatic prostate cancer, according to Stampede trial and more recent Reva trial. The Reva trial screened 180 men, 54 men with recurrent hormone-sensitive prostate cancer, which has 1 to 3 metastases, and radiation therapy improved median progression-free survival, and progression-free survival was significantly better in high-risk mutation status. Stereotactic ablative radiation therapy decreased the risk of new lesions from 16% without radiation, with radiation therapy, and 63% during the follow-up without radiation therapy, and no toxic effect of grade 3 or greater was observed. Go ahead to systemic metastatic prostate cancer treatment, and the most significant update, in my opinion, is a randomized trial which showed us that the efficacy of first oral anti-androgen erlogalix, and in this trial, HERO study, erlogalix was compared with leuprolide, and the primary points was testosterone level during treatment and adverse events. And the conclusion of this trial was that maintained castration testosterone level during 2 months of therapy was 8% higher with erlogalix, and serious cardiovascular adverse events was 2.9 in erlogalix group and 6.2 in leuprolide group. According to current guidelines, metastatic prostate cancer, hormone-sensitive prostate cancer, should be treated with androgen deprivation therapy combined with one of the options, like docetaxel, apalutamide, enzalutamide, or abiraterone. All of this option has category 1, the highest level of evidence, but recent meta-analysis showed us that despite the fact that we don't have head-to-head comparison between these treatment modalities, comparison of systemic treatment in metastatic castration-sensitive prostate cancer, according to this meta-analysis, according to data from 7 randomized controlled trials and more than 7,000 of patients with metastatic hormone-sensitive prostate cancer, showed that an improvement in overall survival is associated with a combination of hormonal therapy with abiraterone acetate, apalutamide, or docetaxel. All of these 3 treatment modalities, all of this medicine was better than other one in a statistically significant way. Again, it was no head-to-head comparison, just regarding randomized controlled trials. And real-world treatment pattern among patients diagnosed with metastatic hormone-sensitive prostate cancer. The data was presented in recent ASCO annual meeting abstract. We know that despite the highest level of evidence and current guidelines, we can see that more than half of patients still receive androgen deprivation therapy, but not combined therapy, how we learned from guidelines. The take-home message: we should discuss combination therapy, including androgen deprivation therapy and systemic or radiation therapy, with all M1 patients. We shouldn't offer surgery for M1 patients outside the clinical trials until we have the data from randomized trials which compared hormonal therapy and combination of hormonal therapy with cytoreductive surgery. Radiation therapy complementary to hormonal therapy improve oncological results in low-volume metastatic hormone-sensitive prostate cancer. Don't offer androgen deprivation therapy as monotherapy to patients if they have no contraindications for combination therapy. However, as we know now, more than half of metastatic prostate cancer patients treated in the real world did not receive first-line therapy. Thank you for your attention.